Greetings, greetings. I'm Dr. Gunzenhauser. I am an interventional radiologist. I've been in practice for about 20 years. I treat a whole host of disease processes and organ systems throughout the body, but today we're going to discuss primarily uterine fibroid disease. We're going to discuss the classification of uterine fibroids, the presentation of symptoms, the workup of patients, our general differential diagnosis, and how we come up with the specific diagnosis. And then we'll talk about the treatment options and look at a few case reports. So uterine fibroids are benign tumors that grow in the wall of the uterus. They're composed primarily of smooth muscle and fibrous elements. They're usually multiple. At least 50% of women in the world experience fibroid disease or have fibroid disease, and about 50% of those are symptomatic enough to warrant treatment. So we tend to classify fibroids based primarily on their location. There are those fibroids that are located along the inner wall of the uterus, and we call those submucosal fibroids. They sometimes project into the endometrial cavity, and we'll discuss that a little bit and show some pictures. The most common fibroids are usually the intramural type, and they're purely within the wall of the uterus. And then there are those fibroids that are located along the outer margin, or the subserosal fibroids. Here's a nice diagram that shows the intramural, purely in the wall fibroids, those submucosal fibroids that project into the endometrial cavity or bulge the endometrial lining. This is the endometrial lining, and here is the endometrial cavity where the baby is, where the blood is. And then there are the subserosal fibroids that bulge or project along the outer margin of the uterus here. There is another type of fibroid, less common, and those are called pedunculated fibroids. And there are those that are pedunculated submucosal fibroids, those that extend off a stalk arising from the endometrial margin and extending into the uterine cavity, and those are called intracavitary fibroids. And then we have the outer wall fibroids that are pedunculated that are called pedunculated subserosal fibroids. So the patient's symptoms are usually dependent on multiple factors, most notably the size of the fibroids, location of the fibroids, and the number of fibroids. You can see on this diagram that the uterus is in the central portion of the endometrial cavity, and so depending on where these fibroids are and how large they are, it depends on how their symptoms exhibit themselves. So I like to separate fibroids and their symptoms into both bleeding or pressure or bulk-related symptoms. The bleeding-related symptoms include heavy menses, bleeding between periods, anemia, lethargy, and tiredness. And the pressure or bulk-related symptoms are pelvic pain, leg pain, back pain, urinary frequency, constipation, back pain, and even infertility and even indigestion. You can see that fibroids that project posteriorly can compress the rectosigmoid and cause constipation. Those that project anterior or even larger posterior ones can press on the urinary bladder and cause urinary frequency or hesitancy or incontinence. And other fibroids can press on the back, on nerves in the back, causing back pain and leg pain. So how do we work these patients up? Well, certainly workup includes a good history and physical. What patients tell us and what our exam shows is always very important. The patient's signs and symptoms are crucial for adequate diagnosis and treatment. And then radiologic imaging usually begins with ultrasound, the easiest modality and cheapest modality, although in some patients we find it necessary to move forward and perform MRI to allow us to find some concomitant conditions at times which we wouldn't be aware of without the MRI. So other conditions can mimic uterine fibroids, and some of those examples are the first being a condition called adenomiosis. Well, adenomiosis involves the glandular tissue along the inner lining of the endometrial cavity. So these little glands along the endometrium produce fluid, and that fluid comes out into the vagina. And those glands, when they become thickened and diseased, they can cause significant pain during periods, and they can cause severe menstrual bleeding. Those adenomyosis can also present when it gets thick enough into a mass-like shape and can actually look and appear like a uterine fibroid. We can also have adnexal masses or ovarian masses that can sometimes mimic fibroids. Uncommon, but that certainly does exist. Uterine contractions can certainly do it, but that usually resolves over time. And then leiomyosarcoma, or a malignancy in the uterus, which is very uncommon, typically less than 1%, can also look like a benign uterine fibroid. So how do we treat patients with fibroids? Well, I tell all patients that if you're not symptomatic enough, you can certainly do nothing at all, okay? And if a patient's 45, 48, 49 years old and they're near menopause, they can certainly wait to menopause, because when you reach menopause, usually the estrogen levels in the blood go down, and usually there's less stimulation on the fibroids, usually the fibroids shrink, and usually the symptoms get better. But that is not all patients, and some patients, even postmenopausally, will experience persistent growth and large fibroids that are symptomatic, and we'll treat them even postmenopausally. The next treatment option is medical therapy. So there are some medical therapies, hormones and birth control pills, that can be used for patients with menorrhagia or heavy vaginal bleeding. Some of those medications can control menses and decrease the bleeding, although in some patients, bleeding is worsened by those medications, and some of those medications can cause significant symptoms. But in some patients, it's certainly worth a try. There is another medication called Lupron. It's an estrogen agonist. It blocks the receptors of estrogen in the fibroids, causing the fibroids to shrink. And it does work and makes the fibroid shrink. However, a lot of those patients experience significant symptoms, and it puts patients in a postmenopausal, in a menopause-like state, with moodiness, irritability, hot flashes, and the like. And when you stop that medication, the fibroids tend to come right back. Then we talk about surgeries. There are usually two surgical options. One is myomectomy, surgically cutting out the fibroids, either through the abdominal wall or through the vagina. And then hysterectomy, taking out the whole uterus, which should be the last option if nothing else works. The treatment that we perform here is something called fibroid embolization or uterine artery embolization. And those are the major options. We're going to talk about those in a little bit more detail. Or you could ignore the doctor's recommendations and do nothing at all. So myomectomy, surgically removing the fibroid, as you can see here, it's a fairly long recovery process. It has a fairly large recurrence rate. And in many patients, they require further treatments. We frequently see a patient who's had myomectomy, and we then need to do uterine artery embolization. So myomectomy is a major surgery. It has a fairly high risk of bleeding, and it also can cause fibrosis and other adhesions, along with other risk factors. Actually, what's interesting is that myomectomy was really the reason that we started doing uterine artery embolization in the first place. Back in the 90s, there was a gynecologist in France who was performing myomectomies and had a fairly high complication rate, and would call a doctor like myself to go in emergently into the operating room and stop the bleeding. And we would do uterine artery embolization. And that was usually done emergently for patients post-myomectomy, post-hysterectomy, and even after childbirth where there was severe bleeding. So what they decided at that time was that instead of having these increased risks of bleeding, they decided to try doing uterine artery embolization prior to myomectomy, 2 weeks prior. And when the patient had the embolization and came to the hospital for the myomectomy 2 weeks later, many of those patients were already saying that they felt better, they had more energy, they had less bloating, they had no bleeding. And that's how uterine artery embolization became a initial primary treatment. Hysterectomy, you can see, has a very long recovery time. There certainly are lots of risk factors with hysterectomy. most notably bleeding, scarring, adhesions, infection, loss of pelvic floor support with urinary incontinence, and decreased sexual drive. So uterine artery embolization that we perform here is really a basic technique. And again, it started as a primary tool back in the 90s, although it was used for uterine artery embolization emergently in the past. And primarily what we do is we decrease the blood flow to the fibroid tumors. So if you look here, first we take the patient into the procedure room and we put an IV in their arm. We give them a little relaxing medicine. We do not use general anesthesia. It's not necessary. The procedure takes about 30 minutes. Under local anesthetic and a little needle hole, we take a small catheter, and the patient typically doesn't feel any of this because they're sedated. And this little catheter goes into the artery in the groin, and we cross over into the left-sided pelvic arteries, and we advance the catheter into the left-sided uterine artery. And what we do is we inject some dye, take some pictures, and then we slowly inject these tiny little particles that go and block the blood supply to the fibroids. Okay, and that causes the fibroids to die and shrink over time. And that shrinkage really begins right away. If you look here, this is a diagram of the uterine vasculature, and you can see here's the uterine artery. It arborizes nicely into the uterus, and it joins multiple other blood vessels that are called the uterovarian anastomotic chain, essentially. So when we decrease the blood supply in this location to the uterine muscle, there's enough blood flow elsewhere to keep the uterus alive, but not enough blood flow for the fibroids to stay alive. And then we keep the patient in the recovery area for about 2 hours and send them home with some medications. Okay, so who should undergo fibroid embolization? Well, certainly premenopausal women that have a decreased quality of life, and even postmenopausal women whose symptoms persist and the fibroids persist in size and severity. Let's look at a couple examples. You can see here, this is an MRI, and you can see this is the endometrial cavity, the white stripe here. This is a big fibroid in the left lateral wall of the uterus. This is a sagittal view of the same thing, and that left lateral fibroid is posterior in location toward the back. And this is the axial plane. And this is the initial pelvic arteriogram, and you can see these uterine arteries coursing centrally into the uterus. This is a catheter that's crossed over like we showed before, and that catheter is sitting into the distal uterine artery. We inject dye, and we see that blood flow courses into the uterus with these little tortuous helicine-type arteries. And then this is post-embolization after we've injected those particles, and those small little branches are gone. This is the right-sided uterine artery. This is an arteriogram of the right uterine artery. You can see the catheter here and coursing down over here. And this is the patient after embolization. There's no flow centrally. Case number 2, we can see here that the uterus is certainly enlarged. It's pressing on the bladder. It's pressing on the spine. There's no space like there should be between the lumbosacral region and the uterus. And there's even some bulging at the anterior abdominal wall. And there's a big fibroid in the posterior wall here. And there's an intracavitary fibroid that's extending into the white endometrial cavity here. This is a coronal plane image of MRI, and you can see that intracavitary fibroid projecting into the endometrial cavity, and you can see it better over here. This whole thing is the uterus. In this patient, you can see the pelvic arteriogram. You can see these large uterine arteries on the right and on the left, and you can see a subtracted image of that. And yet again, and this is enhancement within the uterus, and this is an enhancing fibroid, the one we saw posteriorly. You can see the left uterine artery injection, and this is the prominent and enlarged uterine artery coursing into the uterus, and this is enhancement of the left portion of that fibroid. And this is after embolization, where we've decreased the flow to the uterus and the fibroid. This is the final picture on the left. And here's a picture on the right, a nice large fibroid uterus. And you can see that again, now with enhancement in the uterus. and the enlargement of this fibroid and this lobulated appearance and this kind of heterogeneous pattern. And this is post-embolization on the right side. And this is completely after embolization here, where there's no flow centrally into the uterus. And this is just a picture of pre and no flow post. Okay, so after embolization, we have a beautiful angiographic result. This is how patients usually look prior to embolization, kind of disheveled and unhappy. This is how they look when they're getting ready for embolization. And this is how they look after embolization. They look happy, they look chic, and they're ready to go. So what are our results for uterine artery embolization? We have a 90% clinical success, and that means patients have improved dramatically or completely. Their symptoms are gone completely. They usually have resolution of bleeding after the healing period. We've debulked their fibroid uterus, their mass, and we're able to save their uterus. In conclusion, uterine artery embolization is a non-surgical procedure performed in the outpatient setting. We send patients home 2 hours after the procedure. We do not use general anesthesia. We have a very short recovery period. We can treat all fibroids in one session. The fibroids typically don't recur. There's a small percentage of patients that can undergo something called recanalization, where the arteries can reopen, the heart can pump and rechannel through the closed uterine arteries. Those patients may come back with some new symptoms at 6, 8, or 10 months later, and then we know they have recanalization and may need a little bit more embolization. But that's quite uncommon. Uterine artery embolization still allows patients to undergo all other treatment options. So thank you for your attention, and I'd certainly be happy to answer questions.